So I'm going to be talking about, as is very obvious, healthcare for the homeless. And if you take one message away from my talk tonight, it's really that healthcare for the homeless can serve as a shining example of what healthcare systems can and should be as we move forward more and more away from fee-for-service and toward value-based care systems. This is really a place where we can show that these new approaches to care can shine and how healthcare systems need to morph and change with changing times. My objectives today are to compare the causes of homelessness in San Diego, discuss underlying causes, to describe different efforts to end homelessness, and also what Father Joe's Villages does specifically, to evaluate the connections between health and homelessness, and then last, I'll evaluate strategies to address homelessness through both improved healthcare and also, of course, because you all are public health folks, improved public health. But first, I want to give you a little bit of a backdrop about homelessness in San Diego to give you a sense of the scale of the problem and what the issue is. San Diego County, unfortunately, has the fourth largest homeless population in the United States, behind New York, Los Angeles, and Seattle. On any given night, about 8,576 individuals don't have a consistent place to call home. That doesn't mean that that many people are experiencing homelessness over the course of a year. That's simply a cross-sectional point-in-time count that's done early in the year. We don't know exactly how many people actually experience homelessness in the county of San Diego over the course of a year, but we know it's in the many, many tens of thousands. Service numbers show that every quarter about 15,000 unique people access services. So probably the number is somewhere in the 30+ thousand range in terms of the actual people experiencing homelessness over the course of a given year. So it's a substantial number of people in San Diego that are affected by homelessness. Going along with this, we have major issues with vacancy rates and housing costs. I don't need to tell you all this. Anyone at just about any socioeconomic strata here in San Diego know that this is a challenge, but it's especially so for those at the lowest ends of the socioeconomic spectrum. Vacancy rates for units that are low cost, those units that are $1,200 a month or less, are very, very low, less than 2% any given month. That means that the number of units available for rent on a given day is less than 2%. And if you're a student in the room, I'm sure you know that because you all obviously don't have a lot of income. You all clearly know this problem as well. If we're talking about units $2,000, more than $2,000, in terms of the overall cost of housing in San Diego, more than half of rental units cost more than $2,000 a month. And unfortunately, over the last 6 years, the city of San Diego has lost more than 9,000 what are called single occupancy rooms. These are rooms that people can rent that have a shared bathroom and a shared kitchen. And this loss of these unique housing options has really affected the issue of homelessness here in San Diego. So with that backdrop, I want to talk a little bit more about the underlying causes of homelessness here in San Diego. And this figure on the left here really demonstrates the critical pieces of the problem. What this graph shows is percentage change in rent year by year and percentage change in renter income year by year from the year 2000 to the year 2014. And if you follow that orange line, which starts at 0%, you can see almost every single year during this time period, rent went up. And yet renter income, which is the blue line, was actually negative. And these are all adjusted for year $2,000. So it's all apples to apples comparison. So what we have is a very clear economic mismatch. We have rapidly rising housing costs and stagnant or even decreasing wages. So those two things put together very simply cause homelessness. And I really want to drive this point home that these are the true causes of homelessness on a macroeconomic level. It's not a moral failing of individuals. It's not because we have some crisis in terms of people's ability to take ownership over their own lives, but rather we have a mismatch between two key economic issues in our community. And this is true in other places. It's not just San Diego. We see the same thing happen in Los Angeles, Seattle, New York, and in other large cities that are growing rapidly. often get asked, well, is it alcohol and drug use? Is it mental health issues? What is it that's causing homelessness? And I come back to this issue of these two economic principles and that these are the key drivers. I don't mean to say that alcohol, drug use, mental health issues, and a variety of other things, which I'll talk about today, don't contribute to the problem, but they're not the core parts of the problem. So then the question becomes, how do we end homelessness? What do we do about this? How do we address what's going on? And if we look at it at an individual level, we really have to think about all the possibilities, so both housing and income, but also all these other issues, mental health issues. So is it housing costs? Is it income? Is it educational level? Is it substance and alcohol use or smoking? Is it criminal justice issues, social connectedness, mental health issues, social inequity because of being a minority, a woman, LGBT, whatever it might be? I really think we have to step back to those two key economic principles, even on an individual level, regardless of what somebody's going through. And the reason is this is the least common denominator. Just about every single person who's affected by homelessness has issues with these two key economic drivers of homelessness, housing and income. I don't mean to say that those other issues aren't important. They certainly influence and affect and exacerbate and sometimes cause issues with both housing and income, but we have to, for every single person, look at housing and income. And if we can provide or work with folks to get them into housing, something sustainable, and we can improve income, whatever that looks like, whether that's work, public assistance, or a mix of those two things, that's how we're going to end homelessness. Father Joe's Villages takes the approach of offering comprehensive, innovative services to end homelessness. And we do this under a principle of neighbors helping neighbors. And we're very explicit about this idea of neighbors. In fact, our website is my.neighbor.org. We own that domain name. And the reason is that those experiencing homelessness are often maligned and stigmatized in our communities. And they're not considered neighbors. But guess what? They are our neighbors. There's no denying that they're part of our community. And trying to deny that they're a part of our community means that we're not going to be able to collectively address this issue. And we place the issue more on them and not own this as a community problem that we all have to be a part of solving. And our mission is to provide hope for those who are hopeless and to show the way home for those who have none. In terms of what we do with each person, we really try to approach that person as a unique person. We take one life at a time. Each individual person experiencing homelessness has a unique story, a unique experience, and so the solution to their homelessness is equally unique. So we tailor our interventions to each individual person in order to work with them to move out of homelessness. And this really takes a village. It takes a menu of services, a large menu of services. And this is a list of some of the things that we do. Our most visible programs address the very core issue of housing. Of course, we have residential services. We have interim housing and a temporary bridge structure. Many of you have probably heard a lot about the 3 temporary bridge shelters here in San Diego. We have transitional housing, permanent supportive housing, and affordable housing, which are longer-term interventions. We also have case management and housing navigation services, a day center for those who are on the streets, which is an entry point for those who are experiencing homelessness, a chaplaincy program, a therapeutic child care center, which is state certified and provides child care for folks 0 through kindergarten, and actually takes care of kids who also are the children of employees. So my daughter, for instance, is in child care alongside the families of the children and families who are experiencing homelessness. So unique upbringing for some of the staff's children as well. We have employment and education services, substance and alcohol use disorder services, behavioral health services, programs specific to vets, families, and those with HIV. And last but not least, we have the clinic, the health center. And I list the clinic last, not to say that we're unimportant, but rather we're one of these many services that are available to individuals at Father Joe's Villages. It depends on the person. Maybe they don't need health care services, but we're on this menu so we can individualize the care that we provide to those experiencing homelessness. And a quick note about funding for Father Joe's Villages. This is about the village as a whole. 59% of our combined revenue actually comes from some form of private giving. So we're really dependent in large part, more than half of the money that comes in, on individuals like you, foundations that are supported by donations in order to keep our doors open and do the work that we do. So please keep that in mind as you're thinking about in the future maybe charities to help support and thinking about how you can make an impact in the community here in San Diego. So let's move more specifically into how healthcare and public health systems can specifically help address homelessness and work with those experiencing homelessness. And I'm really going to reflect, as I mentioned earlier, on what the current system is and what it's not, and how healthcare for the homeless can be a test bed for driving innovation in healthcare. I do want to make a brief note about how I categorize some of the interventions. I try to put them neatly into buckets of a public health intervention or a healthcare intervention or social services, but many of the things I'm going to talk about today don't cleanly fall into any of those buckets. And I would argue that really where we're going to make the biggest difference is when we focus on interventions that are the intersection of those three different systems, rather than those systems operating in a silo and separately. And I have no doubt for the MPH students in the room, you all talk a lot about how public health systems sometimes do and don't interact with other parts of social services and healthcare services. It's a challenge that is faced across the whole country. So as we think about healthcare for the homeless, we really have to think about what our patients, our clients are experiencing. And our patients, by and large, have complicated lives. They have a lot going on. I have a number of staff here in the room, and I have no doubt they could each tell you a dozen different stories of patients who just have a ton going on in their lives. Medically, psychiatrically, behaviorally, in terms of their social condition, and a variety of other issues. These are patients that tend to overwhelm healthcare systems. Healthcare providers don't always know what to do, not because they don't care, but because they're set up as healthcare entities, not social service organizations. And of course, those experiencing homelessness deserve the best possible care, as do all of us, as does every single one of us. But what does that mean? What does the best possible care look like in practice? Well, what it is it's often more care than the typical patient, more touches. You have to do more to support that individual because of the complexity in their life. And providers, those working in healthcare for the homeless, really have to be at the cutting edge of what is needed to deliver effective services to those experiencing homelessness. And if we look at the key underlying economic drivers of homelessness, housing, providing housing to folks, or increasing access to housing, and increasing increasing income, healthcare really provides key supports for both of these areas. So I want to first talk about housing and what healthcare can do for housing. What it really comes down to is working with folks on mental health and behavioral health symptom reduction, and also reducing physical health issues, and all of that results in improved well-being. And let me give you some specific examples of how this works. If you have somebody with, say, schizophrenia, who's very psychotic, who's not on medications, their symptoms are poorly controlled, and we put them into some sort of housing program. Let's say we get them into what's called permanent supportive housing, using a housing-first approach. And then that individual is so psychotic that they're banging on the walls in the middle of the night, they're screaming, they're accusing their neighbors of crimes they didn't commit and calling the police, and they're not doing well. You can see very quickly how that housing intervention has a good chance of failing for that individual because of their mental health issues. And the same can go for physical health symptoms. If we take somebody who has uncontrolled diabetes, which results frequently in what we call polyuria, which means peeing a lot, and that person becomes incontinent of urine and they start peeing all over the carpet. You can also see how they could very quickly end up losing their housing due to a physical health issue that's poorly controlled. And I want to take this a step further and say it's not just about supporting housing, but also reframing that housing itself can be considered, and I would argue is a form of healthcare. And the reason for that is that if somebody doesn't have housing to begin with, your ability to address their mental, behavioral health, and medical issues is going to be that much diminished. If we try to work with somebody on the streets who's depressed, drinking heavy amounts of alcohol, and has uncontrolled diabetes, and we just ignore the issue of housing and we don't provide some sort of housing, my ability to make a difference as a doctor for those other issues is not going to be very powerful. Maybe they're drinking because they're depressed, because they're on the streets, and then they don't care about their diabetes, and so they don't do anything about it. So these things all revolve around each other, and so reframing housing as a form of healthcare helps us really get to the core of what's going on. If we talk about income, the very same principles apply. Somebody who has uncontrolled severe mental health issues is also not going to be able to maintain a job, for instance. That will be very difficult to do. And even if they have disability, SSI or SSDI, their ability to meaningfully manage their income in order to support costs that they must incur, food, et cetera, or support them in their housing is not going to be very good. The same thing happens with the example of diabetes. Somebody who's peeing on themselves due to high blood sugars isn't going to be able to keep a job. And all of this then comes together in an improved sense of well-being. If somebody doesn't feel like they're doing well and they don't have a good sense of self-worth, their ability to both manage money, manage a job, and manage housing are going to be impaired in a substantial way. And I told you I didn't want to ignore all of those other factors that sometimes underlie social issues. So I talk a lot about housing and income, but it is really, when we get down to the core of it, also about all of these other social determinants of health. Our patients, by and large, experience a lack of housing, access to food, transportation, income in a consistent manner, familial and social connections, and for some, education. Some of our patients are actually very highly educated. A few of them are physicians themselves. Our patients also, by and large, have a high prevalence of trauma, traumatic brain injuries, stroke, cardiovascular disease, substance and alcohol use disorders, chronic diseases, and severe mental illness. And I want to make a little bit of a mention about trauma specifically. I would actually argue that being homeless on the streets is in and of itself a form of trauma. When you don't know what you're going to do when it's raining outside, when you don't know where you can stay dry and warm, when you don't know when your next meal is coming, when you don't know who's going to beat you up in the middle of the night and steal all your possessions, as we hear stories literally every single day in our clinic, that to me is trauma in and of itself. That is the definition of trauma. So we have to keep all of these things in mind and work with our patients, starting with the issues of housing and income, and then expanding out and saying what else is going on in your life, and individually tailor a plan to address all of these social determinants of health. And doing that really, just like the village, for homelessness as a larger issue, requires a large array of services. And the most important is at the top, which is linkage to other village programs and other community resources, social service organizations who can help address these other social determinants of health. We can't do it by ourselves. But from a more traditional healthcare standpoint, we provide primary care, nurse triage, including same-day access. About 50% of our patients don't show up to their appointments, so we have a huge capacity to get folks in as they come into the clinic. Dental services, including dentures. Behavioral health and psychiatry, also on a walk-in capacity. Substance and alcohol use disorder, including medication-assisted treatment, and I'll talk a lot more about medication-assisted treatment later in this presentation. High-risk case management, which I'll also talk about later. Street outreach, insurance enrollment, and assistance with benefits, including disability, referral assistance, and dispensary services, among a number of other programs, but those are really the highlights. So now I want to talk about how specifically healthcare for the homeless can serve as an example for what we can do in the larger healthcare system. And I specifically want to talk about value-based care. I have no doubt for those that are in public health programs, this is a concept you're talking about in your classes, but I really want to make sure everyone has a common understanding of what value is. What is the definition of value? Value within the context of healthcare is made up of 4 different components. Number 1, improving quality. Number 2, improving patient satisfaction. Number 3, improving provider satisfaction. And that's all over decreasing cost. So it's these 4 components that make up value. And if we can drive up the things on the top of that equation, quality, satisfaction for both patients and providers, and drive down cost, that's where we're going to drive up value. It's not a literal equation where you can just drop in numbers, but more of a concept for thinking about how can we improve our healthcare system. And when you hear about the term the quadruple aim, that's what this is referring to, is these 4 components. It used to be known as the triple aim, and then we realized, oh, wait, the people providing care also need to be doing okay. If they're all burned out and they're not doing well and they're all quitting, well, then we have a problem. And they said, oh, let's add in the providers in there too. Let's make sure we take care of them as well. So that's where triple aim became quadruple aim in the last 5 to 10 years. So as we think about value-based care and homelessness and how this works in that context, we have to think about our patients and what's going on in their lives. Our patients, by and large, have worse health outcomes. They die at a much younger age than age and gender-matched peers. And that's because of how much they have going on, how sick they are, and their social circumstance. And we may not be able to change everything in their lives. We as a, for instance, healthcare entity, or even as a village, aren't going to be able to fix everything in terms of this social issue. We're just one part of the puzzle. But we can make small differences, and we have to believe that we can make some sort of difference in this issue, because if we don't, then we have no basis on which we can start. If we don't believe that we can do something, there's nothing we're going to be able to do. And what I've found, and there is some data to support this, is small interventions in this patient population do make a difference. They can improve care and decrease costs. We can decrease readmission rates, very classically cited quality-related metric and cost-related metric, improve patient satisfaction and decrease cost. And there's a reference at the bottom there, but I will say there's very few references out there if you do a lit search. There is not a lot of research in this area about what specific interventions work. So I'll fully acknowledge in this talk that many of my recommendations and the things I'm talking about are things that we don't yet have the research to fully back up as what we would normally call evidence-based medicine or evidence-based practice. So if you're a public health student looking for a project or some way to help drive forward change when it comes to healthcare for the homeless, this is certainly a good place to start. You could start to look into where there are gaps in research for demonstrating evidence. So in healthcare for the homeless, how do we specifically drive up value? I'm going to talk about a number of places where we can make a substantial difference. The first is thinking about the physical location of services that are provided for those experiencing homelessness, case management services, income support, substance and alcohol use disorder services, and public health level challenges. So let's start with the physical location. Really what I think we need to do in healthcare for the homeless is break out of the traditional 4 walls of physical healthcare organizations, the physical structure. Too often, not just in healthcare for the homeless, but in other patient populations, we expect people to come to us. We expect them to come to our clinic, to our hospital, or whatever it may be, and we don't go to where people are. But that is slowly starting to shift. You're starting to see, for instance, the Kaiser mobile van going out to a large employer and doing some sort of screening test on site, or maybe a dental exam right there, so that employees can just quickly go out during lunch and get an exam, then go back to work. Because we know even in those patient populations, and I have no doubt in student populations, we have busy lives and we have a lot going on, so we don't always do the things that are necessarily recommended. Maybe some of you all know that feeling when you go to the dentist and they tell you to floss. How long do you floss for? How long does that last? Maybe a week? I've been doing it every day for the last couple months. It's stuck this time, because we're doing health promotion. It's stuck. I don't know why. I finally decided to do it consistently. But we all have this challenge. We all have these difficulties when it comes to engaging with healthcare systems and improving health behaviors. So why would we expect those experiencing homelessness to operate any different than anyone else in any other social circumstance? Really, we need to be bringing these services to people where they are. We need to bring healthcare services to them. Unfortunately, in terms of implementing this, especially when it comes to healthcare for the homeless, our healthcare system is broken. It doesn't incentivize this, because currently reimbursement is largely tied to a physical building. You have to deliver it at a location, at an address, and that really limits pushing people to do this kind of work. Our current system also incentivizes high volume, and it definitely doesn't consistently pay for value. And nowhere is this more true than for federally qualified health centers, for those who know how FQHCs are funded, and we are an FQHC. One of the commonly stated goals of the quadruple aim, or value-based care, is to provide care in the right care, is to provide the right care in the right setting at the right time. And the way the system is set up, we're not consistently meeting that goal. So it's really about reframing and saying, how can we do this better in healthcare for the homeless, but also in other areas of our healthcare system. So if we think about the continuum of care for those experiencing homelessness, there's really a number of areas where care is traditionally delivered, just like in any other patient population, in a hospital, a nursing facility like a SNF, a rehab facility, and then in clinics. But the piece we're really missing is what I would say is the bottom of this pyramid, the bottom of this list of locations, which is in the street where people are. And we need to build capacity in order to reach people. And I term this street health, not just street medicine. There's some folks in here I know coming from the street, a local street medicine organization, but street health, taking it a step further and saying it's not just about medicine. And our clinic is actively working on developing street-based healthcare. I want to say that street health is not just mobile health clinics. It's not pulling up an RV on the side of the road and expecting people to come to you. I'm not saying that that doesn't have a role and there's not utility in that and that doesn't fit in the continuum of care, but that's not what street health is. And the reason for that is even that clinical environment having to step into an RV with all of the traditional clinical type things that are in one of those RVs is sometimes a reason people are not going to engage with you. It's a reason they're not going to step in and ask for help, whether that be because they had a bad experience, because they had PTSD, because of mental health symptoms, or whatever it might be. That can be a barrier to care. Street health is also not just outreach workers working on their own and trying to bring back patients to a physical location. Again, I'm not saying that doesn't have a role. It absolutely has a role. We at Father Joe's Villages, in fact, do work like that. Family Health Centers does work like that. But I'm saying that is not street health. That is another activity and a part of this continuum of care. Street health is delivering medical, behavioral health, psychiatry, dental, and other services to those in the streets. It's about reducing barriers. It's about engaging people where they are. And ultimately, the goal isn't to always deliver services to them in the streets, but it's about building relationships, establishing rapport, getting basic health needs met, with the hopes of eventually getting that patient into the door at a more traditional healthcare facility. And we know from some data locally, from PATH specifically, and the Whole Person Wellness Pilot, which is also known as Whole Person Care, that about 30% of the clients they've served and they've been able to connect with, who have been high utilizers of healthcare services in, say, a hospital setting, have not consistently engaged with any social service agency or any outpatient healthcare system. So these are folks that are going to the hospital, leaving the hospital, and then not connecting with anything. They're not going to our clinic, to Family Health Centers, which is the other healthcare for the homeless provider here in San Diego. So clearly we're missing something. We're not reaching a significant chunk of the folks experiencing homelessness. So we have to ask ourselves, how do we do better? And I think this is how we do better. We at Father Joe's Villages are hoping to launch this initiative in full later this year. We started to do a little bit of testing of it. In fact, this past week, a nurse practitioner and a physician assistant actually went to the library at about 6 in the morning and started talking to folks and assessing health needs. We unfortunately had to work on bringing them back to the physical clinic in order to provide more comprehensive services. But we're putting our feet out there and hoping to actually be doing true billable, financially sustainable street health later this year. The work that we really need to do to put this in place, though, is number one, around financial sustainability. So that billing issue is a huge barrier. If we're not paid to do this work, our incentive is not going to be to do this work. We have to bring in money to financially justify and support a program like this. And I want to mention I want to mention San Francisco a little bit here. It's not the only place where this happens, but it's one of the best examples. The county there has actually decided to fund to the tune of around $30 million a street medicine program. So they don't even have to bill Medi-Cal, Medicare, et cetera. The county literally just has set up a program and given a budget to provide these kinds of services. So it's not just even about billability, but about creating other funding structures to support this kind of work long term. There's also limitations, of course, in the kind of care that you can deliver in the streets. You can't do, probably not a good idea to be doing, a biopsy of a mole in the streets. It's probably not the right place to be doing that. So clearly there's things, you can't do a colonoscopy in the streets. I guess you could, but yeah, not gonna work. I don't think licensing authorities would like that. So clearly there's things you cannot do. So we need to think about what's realistic and what's not. And then we also need to say, well, how do we measure effectiveness? What is success in this environment? Is it about engaging folks and then having them come to a physical clinic? Is it about looking at certain health outcomes? And there's not really consistent metrics to look at on a systems level what demonstrates success for a program like this. I'm going to move on now and talk about high-risk case management programs and how they can support healthcare for the homeless. For those that don't really know what high-risk case management is, it's about focusing on those that have the highest risk of poor health outcomes and or those who are the highest utilizers of healthcare services. So we think of a pyramid, most folks in terms of their health risk fall lower on that pyramid. And then there's folks who are middle risk and high risk. High-risk case management, for the most part, focuses on those who are high and medium risk, and there's a variety of programs that focus on subsets within those groups. And I'm going to talk about one at Father Joe's Villages that focused on the highest of the high utilizers. The services that a high-risk case management program provide are typically things like housing navigation if somebody's experiencing homelessness, care management, which means making sure that an individual is able to navigate the healthcare system. Sure, many in the room have gotten a referral or had trouble with their insurance covering something or saying maybe they would cover something and then they don't. And for you and I who are more educated, even navigating that system can be challenging. So in the midst of the chaos of being homeless, trying to navigate that can be near impossible is probably the realistic way of putting it. And then the last piece is social service support, both direct and also connecting individuals to resources within. So now I'm going to talk about a program at Father Joe's Villages specifically called Project 25, which was a high-risk case management program that focused on the absolute highest of the high utilizers. The best example of these folks, there was an individual who was homeless on the streets, who over the course of an entire year spent only 7 days on the streets. The rest of that time, he was either in jail, prison, the hospital, psychiatric ER, admitted to a psychiatric hospital. Think about the costs to society of that individual. Think about that person's quality of life, how they're doing, and then their health outcomes. And you can quickly see how that is somebody who needs a lot of attention and a lot of work and case management in order to improve all of those things. So Project 25 started in 2011. It was funded initially by a grant from the United Way and then from SAMHSA, another grant. And finally, it was paid for by Medi-Cal health plans. And it really delivered an unparalleled level of service. They included daily touches, a focus on harm reduction, and a housing first approach to housing and tenancy support. Some examples of the level of service that this program provided. There was an individual who would regularly have panic attacks and get very mad and punch holes in the walls of the apartment where they lived. And that individual, for that reason, was at high risk of losing housing at that apartment. And we would actually deploy our facilities staff out to the apartment within 24 hours and fix damage to the apartment so that the property manager, the landlord, didn't kick that individual out. So they maintained housing. Another shining example of this level of service with harm reduction, there was an individual who had severe alcoholism who had drank for decades and decades and told us every single time we saw him, I will never stop drinking. I will not stop drinking. I don't care what you tell me, I will never stop drinking. Over years and years and years and years. He ended up with end-stage liver disease. He was dying of liver failure. And we were able to arrange for him to actually go on hospice with a 6-pack of beer a day. He drank his beer. He didn't drink anything else. He wasn't drunk because he had tolerance, and so that didn't really affect him. But he died, a relatively happy man with his 6-pack of beer a day. So it also means reevaluating. A program like this also means reevaluating what does success look like, redefining success. That could have been an individual who died in the streets of liver failure, drinking a half-gallon of vodka a day and going to the emergency department 1 to 2 times a day. To me, this is success. You really have to think about, for that individual, what they want and what their goals are. What does success look like? We showed that this program saved taxpayers $2.6 million for 28 participants over the course of a single year. Unfortunately, Project 25 wound down as a few other programs have started up here in San Diego. I'm excited about some of these other programs, but it's definitely unfortunate to see this very clearly successful program wind down over the last year or so. But I do want to focus on what we have moving forward. So the next big program that's coming in San Diego that I'm particularly excited about is Health Homes. Health Homes is a new Medi-Cal benefit that's going to launch in July of 2019, and it provides complex care management and case management to those who are high utilizers or those with complex health issues. And it does have a specific focus on a subset of those experiencing homelessness. And I'd estimate, just looking at the criteria, probably about 50 to 60% of our patients will meet the criteria for this program. So these are really the folks that we serve at Father Joe's Villages in the health center. It's definitely a program that's going to coordinate with pre-existing case management programs, so whole person care, which is also known as whole person wellness, to try to provide high quality services. But I think what's really exciting about Health Homes is that it provides funds on an unparalleled level to care for the neediest in San Diego. This is a much larger, high-risk case management program than we have ever seen before in San Diego. It's possible that we'll have tens of thousands of individuals on this program here in the county of San Diego. So it's really about scaling programs. We've done a lot of piloting of various programs in San Diego, but frequently what I've noticed is sometimes programs in San Diego, we get excited by the next shiny thing, we go after it, we say, yay, that worked, and then we get excited by the next shiny thing, and we don't scale what worked. And really we should say, oh, that worked, let's do more of that, let's dump more money into that and make that bigger. And so Health Homes is definitely that. Next, I'm going to talk some about income support and how healthcare for the homeless works to support income. The main way we do this, the main way healthcare can assist, is around disability applications, so SSI and SSDI. Having disability for those whom meet the criteria for disability and can apply and get accepted, that income really helps support housing, and it helps drive down homelessness. And it really should be a healthcare service, not just in healthcare for the homeless, but just in the healthcare system at large. But unfortunately, clinicians are in general not adequately trained in the disability application process. Staff are also not very knowledgeable about the process, and the disability process is quite slow. It typically takes 2 to 3 years for disability application to be heard and either rejected or accepted. And then if you end up appealing, it can turn into a many, many more year process. But there's some hope on the road, down the road, and I mean that literally, as the name of the program is HOPE here in San Diego. So there's a federal program called SOAR, known locally as HOPE, that has been around for a number of years that helps address these issues and some of these barriers, specifically how long it takes to get disability. What this program does is it vastly increases access to SSI and SSDI for those who are experiencing homelessness or at risk of homelessness and have a serious mental illness, medical issues, and or co-occurring substance and alcohol use disorders. And this program, SOAR, known as HOPE locally, actually accelerates the disability timeline to as fast as 90 days from a 2 to 3 year process. And when you're talking about trying to work with somebody who's on the streets to get them off the streets and into some sort of stable housing intervention with income to support that, this is a game changer. This really completely alters our ability to make a difference person by person. And I'm excited because there's actually some new funding called HEAP. You're going to hear this word a lot, HEAP, H-E-A-P, so pay attention to that in the news. New HEAP dollars from the state of California that's going to vastly expand SOAR here in San Diego. So keep an eye on that. This is an area of growth. Next, I want to talk about substance and alcohol use disorder services and the role that those treatments and systems can play a significant role. I want to talk about Drug Medi-Cal because this is a program that's changed substantially here in San Diego. Back on July 1st of 2018, the County of San Diego actually took over Drug Medi-Cal, which is one of the main reimbursement mechanisms for those who are offering alcohol and other drug or AOD services here in San Diego. And it actually increased the amount of dollars that folks can get reimbursed for the work that they do. And so it's really created this sudden energy in San Diego around expanding services. But on the flip side, it's also holding providers to a higher standard, and I think a better standard. One of the things that's changing is there's a big focus on harm reduction, things like naloxone, which is known as Narcan, reduced usage if folks are not willing or in a place where they want to quit using, even reducing usage, needle exchanges, and a variety of other programs. There's also a big focus on medication-assisted treatment, which is using medications like methadone, naltrexone, and buprenorphine to treat substance and alcohol use disorders. And I want to talk a little bit about MAT, or medication-assisted treatment, in more detail. MAT is a very evidence-based, so when we talk about all these other interventions, again, there's not a lot of evidence, unfortunately, yet, but MAT, there is quite a lot of evidence that this approach works for substance and alcohol use disorders. Specifically, it works for alcohol and opioids. For opioids, we've actually shown through large studies that it can decrease mortality by up to 59%. And there are few, even on a public health level, few interventions we have that decrease mortality by 59% over the course of a couple of years in a patient population or on a population level. Maybe there's others you all could name. I can't name, I don't think, any off the top of my head that have that degree of reduction in mortality over the course of a short period of time. MAT is unfortunately underutilized. It's something that not a lot of folks get training in. Physicians, NPs, and PAs don't get this training by default when they're trained at most programs. So unfortunately, they don't have the ability to prescribe some of these medications. That's changing slowly, but reduces access that patients have. And the last major issue currently is that there's a lack of same-day access. What I mean by that is when an individual is in a action stage of change, when they're ready to take action and they want to reduce their usage or stop using, you really have to take that as an opportunity to engage with them as much as you absolutely can. And when it comes to medication-assisted treatment, that means getting them medications that same day. If you tell somebody who has a serious issue with addiction, oh, wait a couple weeks, oh, you have this visit, you have that visit, we'll get you the med sometime in the future, you might have just lost that person. Maybe the next day they get depressed, they say, I don't care, they move to another area of town, whatever it might be, you might have lost your opportunity to make a difference in that individual's life. And so I'm particularly proud that at Father Joe's Villages, we are very focused on, especially for buprenorphine, which is also known as Suboxone, on getting patients medication same day. And I don't mean scheduled same day. I mean literally people who walk in and talk to Francis, who's in the second row here and works in our triage office. They walk in, they say, I want to quit. I want to work on this today. And 90+% of the time, they walk out with a prescription to start medication-assisted treatment. I'm not saying all of them have success, and it works for all of them, but we give it a shot. We give it a try. And reducing that barrier can help us make a better difference in decreasing mortality, improving quality of life, and really working on this essential health issue. So now I want to talk about public health. Of course, I'm talking to a public health audience. I need to talk about the public health level challenges and public policy level challenges around healthcare for the homeless. I think Some of the areas where we're doing well, but we have areas for improvement, relate largely to informatics and data sharing. We have a lot of tools here in San Diego to help share information about patients and about the health of those in our community. Those tools include things like the Health Information Exchange, which is also known as San Diego Health Connect, the Community Information Exchange, which is run through 211 now, the Coordinated Entry System, and homeless management information systems, which are tools we use to help optimize where folks go when they come into homeless service agencies so that there's no wrong door. You can access any door and then find a bed or a resource at another organization, for example. These tools really can help us share information, prevent duplication or triplication of services, which happens all too frequently, and ultimately provide better care for those we serve. But there's some significant challenges with these tools. And I think one of the biggest challenges is around privacy, HIPAA and other privacy laws. Laws, both at a federal and a state level, are quite complex when it comes to privacy, and they're very inconsistently interpreted from agency to agency, hospital to hospital, government entity to government entity. You got a room of lawyers together from different hospitals. I have no doubt you'd have a very interesting conversation about privacy law and what that statute means versus that statute. And so getting everyone on the same page to use these tools to share information in an even minimally consistent way is challenging, to say the least. And that really hinders development and implementation of new solutions because people are uncomfortable, scared, worried, don't want to take on the liability of working with these tools. And I would argue this is actually a crisis on a state and national level. This is something that kills people. There's no other way of putting it. These issues literally kill people. So again, public health crowd, if you need a research project, a public policy project, I think this is an area that you could definitely look into. The last challenge with a lot of these informatics tools is around interoperability. What that means is whether or not these tools function well together and can talk to one another in a consistent way. So is the data, the individual pieces of data, do they mesh well? Can they come together? Because if these different systems don't talk to one another, that means asking my staff, for instance, to log into 4 different systems to try to figure out what's going on with an individual person. And that takes time, money, opens up opportunity for error, misunderstanding, et cetera, et cetera. So we have to fix those issues. And folks at those various programs are definitely working on those problems. For instance, the Community Information Exchange and Health Information Exchange are very soon, if not it's already happened within the last week, are to start talking to one another, which is very, very exciting. So there is work being done. The next area that is a major public policy issue is what I call the social services hole. When we think about where people receive health care or where they live, what their social environment is, we could think of a spectrum of different places. From the top being people in the hospital, moving down to skilled nursing facilities, rehab facilities, and if we're talking about those experiencing homelessness, homeless service agencies and other housing interventions, and then at the bottom, those who are on the streets. But we have a hole in the middle where there's not a lot of support for those who are unable to care for themselves, but they don't have coverage for or they don't meet criteria for a higher level of care, for instance, a skilled nursing facility. And this is really a crisis that plays out across the entire country, day in and day out. If you've worked in an emergency department or on an inpatient team, you know this issue. You know the patient that's sent over because they can't care for themselves, and the outpatient team wants them admitted to the hospital, but there's no diagnosis to admit them under. This happens thousands and thousands of times every single day. And this issue really drives homelessness. These are individuals who are very fragile, have a lot going on, and there's not a place for them to go. There are some places where gaps are being filled by some not new, but some more creative solutions, independent living facilities, group homes, and a few other interventions, but they're not really meeting the need ultimately. We need to have better solutions developed, and really at a federal level, there has to be some fix. This can't be a one-off solution that San Diego comes up with, that California comes up with. This needs to be fixed, honestly, by Congress in order to create a better system. There are some things, though, that we can do that are practical on a smaller level. And one is to focus on, for healthcare for the homeless, developing respite care capacity, which is also sometimes called recuperative care. Respite care is acute or post-acute medical care for those who are simply too ill or frail to recover on the streets, but they don't meet criteria to go into the hospital or for a skilled nursing facility for that higher level of care. So a good example of that is somebody who's experienced pneumonia, was admitted to the hospital, and they're coming out of the hospital, and if I'm the inpatient physician, I don't want to admit them into the rain, or discharge them out into the rain. Knowing that they're medically stable to go to a home is very different than sending them out into the rain while they're still coughing and not feeling well. The likelihood they're going to end up back in the hospital and not doing well is very, very high. So that's where programs, respite care programs come into play. Unfortunately, we don't have enough capacity here in the county of San Diego. We don't have enough of these programs. The Rescue Mission just closed their program in January of this year. It was called the Recuperative Care Unit, the RCU. There's a few other programs in town, but there's just simply not enough capacity right now. And this is an essential service to help address homelessness. And it can be a bridge to longer-term housing interventions. If we can stabilize them there, we have the opportunity then to serve folks and get them into some sort of longer-term arrangement. So in conclusion, I want to reinforce or drive home that homelessness is an issue that is extremely important for our community. It affects all of us. It affects those experiencing homelessness. It affects you and I. And we have to collectively come up with solutions to address it. And we can address it by working on the key causes, which are high housing costs and stagnant and decreasing wages. If we can deliver individualized services that address those root causes, we're going to be able to help end homelessness, one life at a time. And healthcare and public health both support this mission and can help individuals exit homelessness. So thank you for coming today. I appreciate you being here. I'm going to make a quick shameless plug for those MPH students out there. We actually have an internship at Father Joe's Villages in the health center. Luke Mellis up here in the second row. Luke, raise your hand. He's the point person. He's an MPH student. He and our staff member. He can plug in. So if you want to work on or explore any of these issues and how you might be able to work on them through Father Joe's, get in touch with Luke.